Welcome, everyone. We're excited to welcome you back to the Ask the Stewie expert video series featuring members of SHEA's Antimicrobial Stewardship Committee. Today, we have Drs. Cunha and Blumenthal to talk through our question of the month. So, Drs. Cunha and Blumenthal, how are you getting nurses involved in stewardship efforts now?
That's a great question, and it's a tough one because nurses are already so busy with their daily activities, particularly during the pandemic. So one of the approaches that we've taken is, first of all, we have nursing representation on our stewardship committee. And we often will ask the nurses, how do they think the best way, or what do they think the best way is for them to be involved with stewardship? And some of the approaches that we and others have taken is involving nursing on questioning the need for urine cultures being obtained within the hospital, assessing patients for transition from intravenous to oral therapy, reminding the team of when to do antibiotic timeouts, and even assessing for penicillin skin allergies in certain patients that may not actually be as allergic as they think they are. In addition to that, just educating nursing on appropriate and proper culture technique, obtaining those blood cultures to minimize the chance of contaminants can go a long way to helping your stewardship efforts at the hospital. And most of that is just dealing with the inpatient setting. When you think about long-term care facilities where nursing can take a prominent role in terms of assessing for possible overtreatment of asymptomatic bacteria, et cetera, you can really, nurses are a very powerful ally when we think about stewardship initiatives.
I totally agree. So thanks for having us here today, but we are doing a lot of those similar things. So I think the traditional nursing role continues to expand, and part of the reason that nurses are so busy and at times overburdened, realistically speaking, with the amount of work that they have to do on a sort of any given shift. But we're grateful for them. And I think each sort of traditional role that they have had, so something like, recording the patient's allergy history, we've tried to expound upon as much as possible, and particularly things like teaching nurses about how to best document what that means. So not just I'm allergic to penicillin or my patient's allergic to penicillin, but the nature of that allergy, the timing of that allergy, and whether or not they've, had other exposures in the past, and sort of to think to the next level on that. And they've done a great job with that, and it's been super helpful. And I think other things that you had mentioned are also very also happening at Boston Children's. So they nurses collect cultures, right? So they're oftentimes the one that's sort of driving thought processes about that. So we have been trying to implement better algorithmic sort of approaches to when to culture patients. So for example, when to blood culture patients appropriately in pediatrics has come up a lot lately. And there's been some new national guidelines that are coming out or just come out. And so we've been working on implementing those with our nursing staff and with our physician staff as well. And then things like when to culture for tracheitis and the ICUs, we've been working on a multi-site QI project on that as well. And so I think the nurses are taking lots of ownership in that, which is excellent, because they're often the ones that are noticing the sort of subtle findings at the bedside. So in the ICU where I work, they're the ones noticing that the sputum is changing thickness or color or something like that. And, what does that mean? And taking that into account on the algorithm, rather than just, somewhat of a knee-jerk response that many people had in the past, not just nurses, to sort of get a culture and start antibiotics and then go from there. And I think that has decreased our antibiotic rate. There's definitely some evidence to show that has decreased our antibiotic rate in the ICUs. Nurses also, as you mentioned, are excellent advocates for IV to PO transitions. That sometimes slips the mind of the providers that are sort of actively thinking about the antimicrobial in more of a class and duration, and maybe not paying as close of attention to the route that's going. And that, not only improves our antimicrobial stewardship, but also improves our risk of central line associated bloodstream infections, and therefore down the line also would improve our antimicrobial use and our patient care in general. So we're super appreciative about that. And then last but not least, and I think, I don't know if this is more relevant in pediatrics, you can tell me, but our nurses do a lot of education with the families about antibiotic use, and they'll help the families get the information sheets that they need about antibiotics if they so request, and help advocate for the families, in particular, like asking questions that the families may not be able to sort of formulate on their own. And so that's super helpful on rounds in particular.
Absolutely true on the adult side as well. And I think you hit the nail on the head. The nurses spend so much more time with these patients than anyone else on the care team. Really, they are a tremendous advocate and a tremendous resource. And, having them do these initiatives and be involved is critical to a stewardship program succeeding.
Agreed. Yeah, we're very grateful for all their help, not just in stewardship, but on every level. But they certainly are incredibly meaningful, and hopefully we'll be involving them more and more. We don't yet have a nurse on our stewardship official sort of team at Boston Children's, at least, and certainly a role that could potentially be expanded in the future.
Thank you for having us. It's been a lot of fun.
Thank you so much.